Hello, my name is Brandy Vogelai, and my clinical issue is naughty cotties. Patients in critical care are more likely to need a Foley catheter. Patients may be immobilized due to injuries or ventilation. There could be a need for accurate INO, or the patient may have urinary retention. My focus will be on Wesley Medical Center, particularly the neurocritical care unit. Wesley Medical Center is a level 1 trauma center and a stroke certified hospital located in Wichita, Kansas. Here is a picture of Wesley Medical Center. If you are unfamiliar because you're not from Wichita or live around Wichita, I found this on their website. The mission statement for Wesley Medical Center is, above all else, we are committed to the care and improvement of human life. Their website lays out the hospital values with the acronym I-CARE. I is for integrity, C for compassion, A for accountability, R for respect, and E for excellence. One of the expectations of the staff is wayfinding. CEO Bill Volich has an expectation that encourages staff to interact with visitors and patients at the hospital. Wayfinding is part of the friendly culture at Wesley, smiling and acknowledging people in the hallways and helping them to find their way to their loved ones or back to the parking lot. Wesley is also a teaching hospital that offers an environment for students in all fields of healthcare. Neurocritical care also upholds this by providing classes both online and in campus so that they can improve the care of their patients and keep staff up to date on best practice. So I'm just going to give a little bit of background here about indwelling Foley catheters and what would be criteria for a patient to have one. I found these criteria on Newson's, an article by Newson in 2014. These criteria are reflected in many articles that I found, as well as the CDC guidelines. So one of the criteria would be acute urinary retention. In case they were, ventilated, sedated, and unable to have control over their bladder, it's just not functioning correctly, we would place a Foley catheter just so that that bladder would drain and there wouldn't be retention. We would use it for accurate INO in critically ill patients, patients that are on a LASIK strip or renal disease, stuff like that, that we would want to keep a close eye on how much was going in and how much was going out. Perioperatively, so if they're going back for a procedure, especially if it's a urologic surgery or a gynecologic surgery, something that kind of deals with that area, they might get a Foley catheter and have that throughout the surgery. It could be removed in PACU, or maybe they would keep it for a day, just depending on the type of surgery, and then get it out as quickly as possible. Another criteria would be a sacral or perineal wound in incontinent patients. We want to keep those wounds clean. We want to keep them from moisture, and that's part of the reason why we would allow a Foley catheter with those patients. Another criteria would be immobilization. As I said before, in critical care, sometimes those patients are not going to get up out of bed. They're going to be ventilated. They're going to be sedated. So they're not going to be getting up to go to the bathroom or being able to use their urinal or bedpan, or tell you when they need to use it. Another criteria would be for comfort at end-of-life care. And I want to just stress it's for end-of-life care. It's the comfort of those patients that are passing, not for the comfort of, I just don't want to get out of bed and go to the bathroom or use the bedside commode or whatever because I'm in pain. Well, we can work on the pain, but you gotta get up and you gotta move. That's how we get better. Talking about that Cauti business. Now let's introduce our naughty villain, catheter-acquired urinary tract infections, or as we know them, Cautis. In an article by Evelyn Lowe et al. In May of 2014, it is pointed out that a Cauti is associated with an increase in mortality rate and in length of stay. Foley catheters provide a direct highway for bacteria to the bladder, which is why we must place Foleys with a sterile procedure. Very, very important. However, even with that being said, the CDC points out that 15 to 25% of patients that come into the hospital will receive a Foley at some point during their stay. And of those 15 to 25% of patients, 75% of them will end up with a hospital-acquired UTI. The risk for a Cauti increases by 5% each day that the catheter remains in place. This is according to the National Clinical Guidelines Center of the UK. So the question is, should we refrain from the drain? With an increased risk of infection with each passing day, and with an increase in mortality and an increase in length of stay, the initial thought is yes. Even with that being said, there are reasons for Foley placement, and those are outlined in the CDC, and I also talked about them in our previous slide. These guidelines need to be followed by nursing staff as well as physicians so that we will only place a Foley if it is actually needed. So how do we stomp out Cautis? As I spoke with leaders at Wesley Medical Center, Cautis are still something that's front of mind. Wesley has made recent updates to policies and has started to implement daily broadcasts to alert nurses of, quote, tube time. Tube time is a reminder to nurses on each shift to check their lines and drains. And that also reminds them to do a CHG bath and assess the need for that Foley. Nurses, therefore, carry a major role in the primary care and prevention of Cautis. As I mentioned earlier, a Cauti can lengthen a patient's stay, but it can also tag on extra cost. This cost is roughly $600 according to Palmer in 2013. That estimated $600 goes towards antibiotics, UAs or urinary cultures, and of course that extra time that they're going to be spending in the hospital. Overall, I think Wesley has put forth great effort to help in the prevention of Cautis. They have established an easy-to-find policy on their intranet for their staff. They have set into motion a, quote, tube time broadcast for their nurses and support staff to remind them to follow up on maintenance and assess all lines and drains. They also require shiftly CHG Foley care to be done and documented. Here is a quote by Lowe in 2014. A systemic review in hospitalized patients reported that the use of an intervention including a reminder to staff that a catheter was in place and or a stop order to promote removal of unnecessary catheters reduced the Cautis rates by 53%. So giving out those tube time broadcasts, making sure that they are like, hey, check your Foleys, check your lines, like sending that out is great, and it promotes the removal if necessary. So I did see room for improvement. Documentation of Foley placement and discontinuation is not always done in real time. And I think that if it's not done in real time, sometimes that leaves room for it being missed. So Foley being placed and not documented, there's nothing there for until like a nurse notices, like when they go to document on that Foley, hey, there's a Foley there, there's nothing to document. We need to know when that's Foley's placed. We need to know how long it's been there and is it time to get it out. And sometimes it's even missed that it was taken out, and they DC the Foley, send them to a lower level of care, and that nurse is receiving the patient, not documenting on a Foley because there isn't a Foley, and then it pops up that, hey, this patient has a Foley. Well, they don't have a Foley. So how long did they have this Foley? When was it taken out? Was it 2 days ago, 3 days ago? That's all important documentation to help prevent Cautis. Another area that I saw that could be improved was the initial assessment for Foley's is done in the mornings or at the beginning of the night shift. So especially for day shift, I think it is so important to give those patients a chance to prove that they don't need that Foley. Maybe they were extubated that day. Maybe PT and OT worked with them and they were able to get up and get out of bed and actually make it to like a bedside commode or to the toilet. I think that doing an assessment closer to the end of shift by these nurses would help benefit, because then they're actually focusing on, does this patient need this Foley? Does this patient qualify any of the criteria that would say, yes, this patient is a Foley candidate still? Just switching up when assessments are done. I also think that Wesley could introduce a program, something that promotes a routine education and following up on Foley maintenance, either by a manager or a champion. Having a champion on the unit or in each area of the hospital that can speak to the guidelines that are laid out by the CDC and can keep staff informed and promote best practice. Lowe in 2014 had a quote here. A statewide intervention in Michigan introduced a bladder bundle to decrease Cautis using a collaborative model and strategy to facilitate an implementation, including engage and educate, execute, and evaluate. So by setting forth a bundle, something that is like this, just like a sepsis bundle. Like if you have a catheter, you are going to follow these steps. You are going to, on day 2, like really try to get that out. Like, okay, let's call PT, let's call OT, let's get this patient up, let's get them moving, see if we can get this Foley out if maybe they're immobilized. Just making a time frame, educating the patients on, hey, let's do this, let's get up, because if you get up, we can get it out. Because very likely that patient doesn't want a Foley either, and they're not exactly comfortable from my understanding. So I think those are just some areas for improvement. Education is medicine. Overall, I think continuing to educate nurses and their support staff, like the CNAs, the techs, on the proper use, care, and care of Foleys will go a long, long way. Letting them know like who actually needs to have a Foley, making sure there's no loops. I know nurses usually know that, but maybe their techs, they go in there, they empty, they do their thing, and they don't necessarily pay attention to how the catheter is sitting or how the loop is going with it. Knowing when they should be emptying a bag. Is this patient peeing on a Lasix strip? Are they just filling this bag up? Well, we need to make sure that we're educating to the bag being emptied frequently, so that it doesn't cause a source of infection because it's backing up. Either using online education that can be done annually, or having a champion, as I talked about earlier, that can just follow up on guidelines and speak to the best practice. Thinking of health, I think that healthcare is growing, and we're kind of trying to move away from invasive urinary catheters, the indwelling urinary catheters, to a more non-invasive urinary containment device. Devices such as condom caths, which have been around for a while, but there's still some improvements that could be there. And now we're seeing the PureWicks, which are coming out, which are for females. I think that they're putting forth great alternatives to an indwelling Foley catheter, but I still think that they're is some improvements that will be needed, but that's just going to take time. Here are my references. I hope you enjoyed your Cauti education and you're ready to get out there and stomp out some naughty Cautis.